Okay, so now we're going to hear some more discussion about an issue that's been alluded to several times already, and that's about consent for research in the learning healthcare system. The first speaker is going to be Dr. David Wendler from the NIH Clinical Center, Department of Bioethics.
All right, good afternoon. So I'm going to talk about different models of consent, and I'm, maybe like some previous speakers, just going to make this stuff up, and I don't speak for anybody other than myself. I try to speak for myself. So I actually try to say things I agree with at least a little bit later on, maybe like previous speakers. So what I'm going to talk about, so this is the kind of example I have in mind, a pretty simple example of comparative effectiveness learning healthcare kind of trial, two similar interventions, both of which are within acceptable care. And then I want to ask two questions about that kind of trial. Should you get consent? And if so, how should you get it? And I'll give you my basic bias punchline, which is I'm a big fan, for the most part, of telling people what you're doing and what they're involved in, but I think we can typically do that in a very quick, easy way, and it doesn't have to be as onerous, extensive, as burdensome as we've often made it. So I think there are 6 models of consent. I'll talk about each one of them in turn. I think that for the most part, which one is going to be appropriate is going to depend. Going back to it depends, it's going to depend to a certain extent on the nature of the study, the nature of the patient population, although I'll argue in general some of them are better than others. And then just at the end, I'll talk very briefly, and if people are interested, we talk more about timing of consent, having the consent not roughly when the person's enrolled in the trial, but how about doing it much earlier, or how about actually doing it after they've been randomized. So full regulatory consent, this is when everybody's in the audience is supposed to start booing as a possibility. So as everybody knows, this has gotten long, it's gotten onerous, it's gotten extensive. And as I actually try to convince people, to the extent that what we're supposed to be doing, what the Belmont Report claims we're supposed to be doing is respecting autonomy, we have really good reason to believe this doesn't do it. Right? The more information you give people, you overwhelm them, we get really, really bad at making decisions for ourselves in the face of extensive information. So it doesn't work even for what it's supposed to be doing. So here's what we've heard is typically the response is, okay, if full regulatory consent is not going to work, okay, maybe you can't do a 30-page consent form, well, then we're just going to have to waive or alter consent. We won't get consent at all. And I think obviously full consent seems particularly problematic in this setting. Not only does it undermine autonomy, but I think it undermines at least most pragmatic trials. It makes them dramatically less pragmatic than they would be otherwise. And as we've heard, what I always hear this, the initial reaction from investigators, oh, let's just completely waive consent altogether. So people have probably seen these more than they want to. These are the conditions for waiving consent, so you have to meet these conditions. And of course, the important point here is that if you meet these conditions, the conditions for waiving the requirements are the same as the conditions for altering the requirements. So what happens is people, once they satisfy these, go to just full waiver when maybe what would be more appropriate, I'm going to argue, in a lot of cases, is actually altering and just doing a more truncated process, but actually getting some consent. All right, so you've satisfied them. You try to do no notification and no consent. We're not going to tell anybody anything. We're not going to ask them for anything. We're just going to do research for them. Advocates for this tend to argue that, at least for a lot of pragmatic trials, there are very few, if any, prospectively identified risks, so why not? In some cases, I think this does make sense. In most cases, I think it's a terrible idea. And the question is, why not? Even if there are low risks, why should we care about consent? So a little bit of data. This first data comes from a study that David and Ben were involved in, asking people just for medical record review. We're going to do a study that involves medical record review. What kind of consent would you like? There are a couple people who said, don't need to know about it at all, but no, that's a dramatic minority of the people who are involved. Most people wanted to at least hear about it. Some people wanted to give verbal consent, and some people wanted to give written consent. There's a really interesting one of the early articles by Ruth Faden and her group presents this as an example where you don't need consent at all. So it's not clear whether or not the philosophical analysis agrees with the data. Now, at least as I understand these guys' study, the people involved in this thought that maybe these kinds of trials posed a little bit of extra risk. So maybe what they were playing on here was the fact that there's extra risk, and that's why they wanted to know. So this is actually a study that we did a little while ago. Rahul Nayak is a previous wonderful fellow in our department, where we asked people about consent for pragmatic trials. And the first thing to notice is we were trying to make clear that this was a trial where there weren't any prospectively incremental research risks. And most people understood that. 80% of people understood that. And then we asked them what they thought about consent. And despite people saying, yeah, I know there aren't any added risks, majority of people still wanted to give consent for those trials. So basically that just asks the question, well, what's going on here? If there's no added risks, why are we getting consent? What do people want to be told about, and what do they want to give consent to? So I'm a philosopher. You'll get a little bit of philosophy here. This is the first bit of it. It's that enrolling in a trial is more than just about the incremental risks that you might face as a result of being in the trial. I think it's about at least two other things. One, David was talking about relationships before. If you're with a clinician and that's clinical care, that's a particular kind of relationship. Now, how we should understand that relationship in the era of electronic medical records we could talk about, but it's a particular kind of relationship. If that's actually a researcher, that's a different relationship that you're involved in, and typically people want to know what types of relationships they're involved in. The second thing is that when you're participating in a trial, you're contributing to the results of that trial, and in general, people like to know what they are and what they're not contributing to. So I think there are things to tell people and for people to consent to, even if you're confident that the study doesn't pose added risks. And we could talk about that, but a lot of times you can't be confident that that's true. So what are options for that? So next one is general notification plus or minus opt-out. You could put posters around your ICU or put posters in your emergency room. You could post something on your website. Here's the kinds of trials that we're doing. If there's opt-out, you could even say, if you don't want to do this, call this number, talk to your nurse, do whatever you have to do. So one virtue is if people actually get the information, then they've at least heard about the trials. If you add opt-out, then they can decide not to be in the trial if they'd rather not be in the trial. Biggest worry about this is in terms of how it's implemented. A lot of times you get worried the ways of studies I've heard and how they try to implement general notification. And I wonder, does anybody really ever see those signs? Is there anybody who was in this trial who really knew that they're in this trial? So I suspect in a lot of cases the answer is no. That might be okay, but then I don't think we should kid ourselves too much that we're doing very much by these notices if nobody's really noticing them. So what's that get us to? So instead of just a general notification, what if we just actually talk to the extent that we can, we say something to the people who are going to be in the trial. So this is brief verbal disclosure, and you could have plus or minus opt-out. So at least you're telling them about the specific trial. So I think that's a benefit over something like general notification. They're hearing something about the specific trial. And then if you have opt-out, as we heard an example earlier, then that person can decide if they don't want to be, not to be in the trial. This, I think, depends so much on the details of how it's done. If you do brief verbal disclosure with opt-out in a certain way, it actually looks a lot like general notification. If you do it in a fairly intense way, I think it actually becomes very close to opt-in. And I think sometimes the difference between opt-out and opt-in can be very difficult to discern. I'll actually give you an example about that in a minute. So to the extent that this is really general notification, it inherits all the problems of general notification. To the extent it's really opt-in, then I think we need to figure out the right way to do opt-in. So those are the challenges I think that the first couple of models present. I think they probably work for some trials. Personally, I think for most trials, they're not a good idea. So what we want is something that tells them about the specific trial, really gives them a chance to decide whether or not to participate to the extent that being in the trial is voluntary. And we still are in a learning healthcare pragmatic setting, so we want to try to minimize the extent to which we're deviating from real-world settings. We don't want some research consent process that's dramatically different than what really goes on in the clinic. So here's basically what I think about it. So the yellow boxes, I don't think we really know what goes on in clinical consent. You know, whenever I go to the doctor, basically nothing goes on for my clinical consent, but whatever it is in that box, that's not our question today. We could talk about that as an interesting question. But for me, it's what goes in the red box. So if we're going to have a learning healthcare system and we're going to get some kind of research consent, then basically what we're doing is we're going to have clinical consent plus something. So what is the extra thing that we should be adding? So here's the example that two of my most favorite beloved colleagues gave. So their claim was, in this setting of the kind of trial that I'm imagining, where there are little, if no, added risks, what's the difference between clinical care and being in a research trial? And that'll tell us what we should put in that box. Well, their answer is that the material difference is randomization. That when you're in a clinical care setting, you don't get randomized. When you're at least in a randomized trial, you do get randomized. So here's their suggestion basically for what goes in that red box I had before. Basically, you say we're doing a randomized trial, it's going to be random, here's why we randomize people. And then you say this, so I love this. This is what I was saying before about how opt-in and opt-out get very close together. Here's what they recommend you say. So unless you have a preference for drug A or drug B, I'd like to include you in the study. I was like, is that opt-in or is that opt-out? Or it's something between opt-in or opt-out? Or it depends how vigorously the person says, I'm going to include you in the study versus, well, you know, if you want to be in this study. So this is basically their view. I don't know whether it's opt-in or opt-out. The other thing I think, as I mentioned before, I think it's just false that the primary material difference between a clinical trial and clinical care is randomization. The first way you know that is there are a lot of clinical trials that aren't randomized. If that were the only material difference, then those things wouldn't be research. Of course, there's still research. There's other things that are differences. There's the contribution to the study, the collecting knowledge. That's, I think, what's really important. So there's some virtues of this approach, and I think it's a great approach for a lot of trials. Small burden, that wasn't very much extra that you had to say. People are really informed. Depending upon, as I said, I'm not exactly sure, maybe it depends how it's presented, whether it's opt-in or opt-out, but at least there's this opportunity for the person to object and say, no, I really want A, or I really want B. I'll just go get that from my doctor. Here's a trial we did with Neil Diekert at Emory, who's a cardiologist at Emory. So basically, we wanted to see, there are some data that people have now collected about pragmatic trials in general. So what we wanted to see is whether or not people's preferences with respect to consent for a pragmatic trial differed in an acute setting. So this is a setting of a trial for myocardial infarction where you think, even if you could argue whether you really call it minimal risk, but there's a lot at stake in these kinds of trials. And so we thought maybe more people would be insisting on getting written consent. It's actually not what we found. The majority of people were willing to have verbal consent, and 36% preferred written consent. It's interesting, I think, to compare this to the data these guys got. You might think it's inconsistent, but I actually think it probably is consistent. I think it's just that the patients are actually more sensitive to the setting, and they're willing to adjust the kind of consent that they want and will expect based on the setting. And I think in this case, they realized, okay, I'm having a heart attack. Do I want somebody to give me a form and have me read through a form? No, they recognize that's probably ridiculous. Let's figure out a different way to do that. Now, the problem here is, and we bring our IRB person back, to the question of how many of these trials really satisfy those four conditions. How many of them is your IRB going to agree it's minimal risk, it's not practical to get consent, it's not undermining the rights and welfare of subjects. These are two really nice papers on this where people are interested. Basically, the first one by Ross McKinney and some of his colleagues argues, you know, almost all of these things probably satisfy those four conditions. You could waiver alter for most of them. The second one is a more recent paper that argues hardly any of these trials are actually truly satisfying those four conditions. So it shows how much consensus we've got on that question. I don't know how many do or a percentage, but obviously there's going to be a number that don't. And so what do we do with those? So this is what I've been trying to argue for. I was trying to think of how successful I've been. Maybe I have like a 3 to 5% success rate in trying to convince people of this that I work with. I'm on a protocol review committee for bone marrow transplant studies across the US, and trying to think, you know, you could actually satisfy the regs and consent without a 35-page consent form. It's actually possible to do it in a lot of cases. I think in most cases we actually can do it, and here's the argument. I think now OHRP has actually given the argument for it. So here's the new standard, right, in the revised regs. Here's how we're supposed to decide what goes into a consent form and what's communicated through the consent process. It's what does a reasonable person want to know to make the decision in question? What does a reasonable person want to know? That's the answer. And if we can answer that question, that's what we put in that red box that I had on the previous slide. And again, it does. It depends, right? It depends a lot on the context. So what is the context here? The context is basically, the example I have is, we have two different standard interventions. We don't know which one is better. One could be better or worse. So being in the trial and being randomized might be better for you. It might be worse for you. It might not make a difference for you. What do a reasonable person want to know in that setting? So again, so this is my second attempt. You have to put up with a philosopher and me twice. Philosophers use analogy. So I'm going to think of a completely different context to think about. Get us away from research for a second. I live in the middle of Washington, D.C. This happened to me a couple of years ago. I was coming home. I would take the metro to work. I was coming home. This guy couldn't get his phone to work. And it's like, which way is the way to the White House? I actually wanted him to drop something off for me. It just turned out I was going to go that way, but it was out of my way. It's one of the good ways he could go to the White House, but it wasn't the only way. There's like 3 or 4 options of how you can get from Adams Morgan to the White House, and you can go down 16th Street, you can go down 18th Street, you can go down Connecticut Avenue. I wanted to know, would he do me this favor and pick the one option that would allow him to take my letter? So he's got a choice here, right? The path that he takes to drop off my letter could be the path that his phone would have recommended if he had waited 3 minutes for the website to come up, or it could have been the one he just picked randomly, or it could be different. And that difference could make a difference, or it could make no difference at all in his life. So the question is, what does a reasonable person want to know to decide and make that decision? Well, here's what we do now, right? I can tell you all these differences. It turns out that there are an extraordinary number of differences in the walks you go from my house neighborhood to the White House. Some of the sidewalks are good, some of the sidewalks are bad. Some have these really interesting things to see, some don't have very interesting things to see. Some of them have a lot of traffic, some of them don't have a lot of traffic. Some have ambulances that might run you over. Some have interesting things to see. And then there's the non-healthcare worries, like 14th Street used to have a lot of prostitutes. You might like that, you might not like that. Some have interesting architecture, some don't. So I think, all right, I'm trained in research ethics. I know this is going to be really hard, but the sidewalks, if you go this way, are really nice, but then the flowers are better this way. Right? I get 2 minutes into that, and the guy's just going to be like, this person's insane, right? I asked a crazy person how to get to the White House. But I was actually trying to be nice. I was trying to help this guy, and the question is, what went wrong? And that's what we're doing in research, right? That's what we're doing in these trials right now when I review these 35-page consent forms for bone marrow transplant trials. That's exactly what's going on, and it's confusing people. So what's going on? There's a couple of things I think that are going on. One is we just want to give them the information we need, and we forget reasonable people care about more than just the information. They care about things like how much of your time. They don't want you to take up all of their time. They maybe don't want to sit with you for 2 hours and go over a consent form. Maybe they don't like that. Maybe they don't want you to annoy them with all of these idiosyncratic, trivial differences that they don't care about. So that's one thing. People care about more than one thing. A second thing is that the way we communicate with each other is very sensitive in ways we don't realize to the specific context. And the more information you give somebody, that signals something about the kind of decision you're asking them to make. If you give somebody a lot of information, then that suggests that they've got an important decision to make. And if they don't think they do, like they think they're just walking to the White House, and you talk to them for half an hour, they're going to think, this guy's not telling me something. There's something here that's going on. Or they're telling me they don't know whether A or B is better, but he's talking to me for 45 minutes about the differences between the two of them. Like, he's hiding something here, and he's just afraid to tell me, right? So when we're not hiding anything, you shouldn't do this, right? Because, again, you're just going to confuse people. And the third thing we know is machine learning. We're not computers. We're not very good at taking a lot of information. So a recent study I looked at suggests human beings are pretty good at up to 3 options. You give them more than 3 options, and we just completely fall apart. And we do things like, we just pick the last option you mentioned, or we pick the first option you mentioned, or we pick the option that seems the most interesting, and we just lose the ability to make rational decisions. And this leads us to making suboptimal decisions for ourselves. So don't do this. We shouldn't be doing this with any of our research subjects. So how do we do it? And I actually think, and this is the point I was going to argue for, there's a way to do this within the regulations of giving the information that a reasonable person would want. You give the salient information. You don't try to figure out whether they care about architecture or flowers or intersections or sidewalks. You give them this salient information, and then you just ask them, do you have any questions? Is there anything else you'd like to know about this? So this is what I was calling targeted consent. And so basically it has two parts. It has a verbal part like the brief verbal disclosure. Put in there the salient information, and just put everything else into a written form which the person can read if they want to read it. And so I think you just basically tell them it's research, basic plan about the research. If there are added risks, explain those to them. And then just explain it's voluntary, it's up to them, and then ask them if they have any questions or not. All the other mandated information can go in to the consent form. So here's basically the way I think we should be doing something like this. You basically just say this to them. Now we can argue about this, but notice I am worked very hard. The word randomization is not included here. I don't think we need to say the word randomization to anybody when we're doing these sorts of trials. We tell them you might get A, you might get B. Do you have any questions? That's what I'm proposing to be in that red box, and I don't think that takes too long. And then if you give them the form, I think you've satisfied what a reasonable person wants, and so you've satisfied the federal regulations. So all this other stuff just goes into the consent form sort of as it's described here. Okay, two last things I'll talk about, which are just very quickly talking about timing. So typically when we do a trial and you're getting consent, the thought is you roughly get consent just before you randomize the person and enroll them into the trial. So people, particularly with respect to now learning healthcare systems, have been considering at least two variations on this theme. One is, and Christine's going to talk in a minute more about broad consent, so I'm just going to call this broad consent as a segue to her talk, but there have been a number of papers where people are arguing, particularly, let's say we're doing lots of trials at Mount Sinai. Rather than getting consent for each one at the time we're going to enroll the person, what if we do this? What if when people come into the Mount Sinai healthcare system, we talk to them about the fact that we do trials and the kinds of trials that we do, and that we're going to possibly enroll them in certain kinds of trials and use information from their medical records to develop generalizable knowledge. And then there's less information at the time of actual enrollment in the trial. We've already gotten this prospective agreement from them. So a number of people, this is my colleague Scott Kim, as one of the people who's been working on this. And I think it's an interesting question, and the question is, to what extent do you think that is? To what extent would your IRB think that that's sufficient for getting consent for these types of trials? I also don't know of any. Be interested if everybody knows of any relevant data on this. I don't know of any data. There's tons of data on broad consent for the use of samples and data, but I don't know of any data on people's views with respect to this kind of broad consent. It'd be nice to get it. The second thing is post-randomization. So this is actually described by a statistician a long time ago. People have started arguing about it again, and so basically the idea here is what you do is you randomize people first, and then you get their consent. For the type of trial that I described, I don't think it really makes that much of a difference when you've got two interventions that are very similar, because it's easy to describe both of them at the same time. But one thought about this is that this is a nice approach to use when the interventions are going to be really different. So maybe it's surgery versus it's clinical care, or maybe it's rehab versus surgery, or maybe it's some new intervention versus standard of care. So when the interventions are very different, it can be complicated to describe both options to people. And then you might think, why describe both of them to them when they're going to get randomized? They're only going to get offered one or the other. Why do they need to know about both of them? So the thought is what you do is you randomize them first, and then you get their consent to the one to which they've been randomized. This has at least some virtues, has some drawbacks we could talk about. Some people think it's ethically problematic for this kind of trial, and for, I don't know, keep apart the argument, I think it's, don't worry about it, it's actually not ethically problematic. It's perfectly fine in most cases to do this ethically. This is my argument for it. If you're interested in it, we could talk about it more, but the basic argument is that nobody worries about random sampling. So nobody worries if I go into an ER and I just say, I'm going to pick that person, and that person, and I'm going to survey them. Nobody says, Well, you know what? You've got to tell the other people that they didn't get sampled to be in your survey, right? The answer is, no, I don't. And when you're doing this and you're comparing standard of care to an intervention, experimental intervention, and some people are just going to get regular standard of care. They're like the people who just sit in that room and you don't sample out. That's how that works. And so if you don't need it in the one case, you don't need it in the other. May convince absolutely nobody, but I'm happy to make more of an argument if people are interested. And this is from another one of our wonderful fellows, David Miller. We did a survey of the US public to see what they thought about post-randomization consent, and there's pretty strong support for it. About 3/4 of people thought it was perfectly fine way to get consent. There were about 4% of people who didn't like it, and you might wonder, I guess, what we do with those numbers and whether or not it's okay to do it, even if there are at least some number of people who don't like it. Okay, thank you. This is my summary. No words, it's just going to be colors. There's 6 models. I think the ones in red, for the most part, are bad ideas. I think the ones in yellow can be good ideas in some cases and not good ideas in others. The last ones were supposed to be green. I don't know if that looks actually green. And I think in most cases, they are typically very good ideas. Okay, thank you.
Okay, so the next speaker is going to talk about the consent for the data and the samples that are collected in the learning healthcare system. And that's Christine Grady, also from the NIH Clinical Center, Department of Bioethics.
Yep, we invaded you this afternoon. So first I want to say good afternoon and thank you for inviting me, Rosamond. It's nice to be here. And I'm sorry that we weren't here this morning. We missed all of the good conversation this morning. So I'm going to talk about consent for secondary use of samples and data collected in learning healthcare systems, which is different from what Dave was just talking about, and I'm going to hopefully convince you why it is different. So the first thing I'm going to try to do is distinguish secondary use. What does secondary use mean, and why is it different? And then recount some of the debates that have been ongoing about consent for secondary use of data and samples. Some of these will be familiar to you. There are questions about when is this human subjects research and subject to the regulations, when and if is consent needed, and if so, when. If consent is needed, what model is appropriate? Is there a difference between data and samples in thinking about secondary use? And then some of the implications for learning healthcare systems. So to start with, what is secondary use? So, primary research is when you're collecting data or samples to be used now. You have interaction with the person from whom you're collecting them, and it, by regulations, is human subjects research because you're having an interaction with the individual to collect those data. Secondary, on the other hand, is use of data or samples that were collected in some other context. So some of that is a non-research context. There might be leftover blood from a routine clinical test, medical record data, and information from other kinds of sources like the census or mobile apps or social media, etc. Also, secondary use can be using samples or data that were collected in prior research studies. So there may be, again, leftover blood samples or data or samples that are in repositories or biobanks, and those are then available for use. So the difference in secondary research is that there's generally no interaction with the person for the present research purposes, and by regulations, by our federal regulations, that doesn't count, it only counts as human subjects research if those data or samples are identifiable. And we heard from Dr. Martin what the problems are with that word, but that's what the regulations say. So I think everybody knows we've been doing secondary research with samples and data forever. Anybody who's done research for a long time knows, you collected data, you put it in your file cabinet, and then maybe you went back to it sometime later and said, there's another question I can answer from these data. But we also know that research has changed. The amount of samples and the amount of data that are available for research purposes is just enormous. There are billions, according to SACHARP, for example, there are billions of stored samples available for research use. And the amount of data that is being collected and stored and possibly used for research is amassing at such an incredible rate that I don't think anybody can even quantify it. In fact, we're having trouble finding places to store it. So research has changed, and most people believe that the power of this volume of data or samples creates opportunities to answer questions that we couldn't answer before. But it is interesting when we think about consent, which is what I'm supposed to talk about, and that is there's no human here. You get the sample from, or the data from a repository or shared from another investigator or a clinical environment, and you put it together with lots of other kinds of data and information and create a research project in that way. There is no human being that you're relying on. And in fact, most of the time, the data that you're using for secondary research is not data that you had anything to do with collecting in the beginning, or samples that you had anything to do with in the beginning. So that creates lots of really interesting research ethics challenges. The first is it research with human subjects? It doesn't even count as that, and therefore does it require IRB review? Is informed consent necessary? And if so, why? What are the risks of this kind of research? What are the benefits of these kinds of research? And who controls these things? Who controls these data and samples? And these are all debates that have been swirling around for a while. In my view, and perhaps it's a biased view, most of the attention has gone to informed consent with secondary use. What is the right thing to do with respect to consent? Some of that attention has been fueled by some of these stories, which I'm sure many of you are familiar with. The Henrietta Lacks story, where tumor tissue was taken and created a cell line, which became a lucrative cell line and has been used for lots of important research and made lots of people lots of money. The Havasupai Indian tribe case, in which samples were collected with consent for a specific purpose, and then used for a different purpose in a non-identifiable way, but created group harm for the tribe. And then the newborn blood spot situation, where in several states, when parents found out that their newborn heel samples were being saved in dried blood spots for future research, they said, that's wrong, you have to destroy them, and millions of samples were destroyed. So all of these things got, I think, the public thinking about, what is the right way to ask our permission for using our samples for future research. And interestingly, in each of those cases, the regulations were not violated. Secondary research of de-identified specimens, as we've heard, was not considered human subjects research under the federal regulations, and consent was not required. Of course, in Henrietta Lacks' day, we didn't have the federal regulations yet, but in the other two, we did, and there was no real violation of the regulations. As many of you know, the common rule was recently revised, and in the process, in the notice of proposed rulemaking, was introduced the idea of requiring consent for all biospecimen research using something that was called in that NPRM broad consent. And that led to huge controversy in debate about whether broad consent should be required. And the final common rule revisions, which were published in 2017 and are now in effect, did not adopt that and still allow research use of de-identified specimens and data without consent, and also allow a new kind of broad consent in the regulations. So the regulations give us some interesting options. So under the new common rule, in the green box is primary research, and that, for the most part, requires IRB review, and the IRB, as you heard from Dr. Martin, could decide to waive consent in those cases, but the IRB has to look at it. For secondary research, it totally depends on whether the specimen or the data are identifiable or not. And if they're not identifiable over here, then it's not research by the regulations and doesn't require either review or consent. If it is identifiable, then there's a whole host of options. It can go for full IRB review and then get specific consent or a waiver of consent. It can satisfy exemption criteria and then get limited IRB consent and IRB review and broad consent, or it can be exempt and no consent is required. So the rules set up lots of different options. I think what's important about these things, about the current situation, are several things. One is that there is a big distinction in the rules between primary and secondary research. There's also a distinction between identifiable and de-identified data and specimens. There are multiple options for what happens in secondary research, and the rule does not distinguish in any way data from samples. And those are important caveats. So what about data? So we know that research using medical records, medical information repositories, and data associated with samples has been the subject of what comes under the secondary use of data rules in the regulations. But now we have all this interesting information that was collected outside of clinical or research settings, digital information that's collected through our smartphones and through our credit scores and through our use of apps and wearables that David Magnus talked about before. And this is used for health-related research. And in the click-through agreements that nobody reads, there often is a statement that this might be used for research, but nobody gets that far in the click-through agreement to begin with. And people have noted, and I think it's true, that most of us who check the box and say, yes, we want this program or we want to use this app, we don't imagine researchers as among the users of the research, of the data, excuse me. So data has an interesting distinction. And this year, of course, there's a lot of attention to how people are using our data. This is just one article that I found in this online journal called Fast Company. And it was a very interesting story because it talked about how health data is sold by healthcare providers to lots of third parties without asking anybody. And in fact, most of the laws in the United States protect the right of the healthcare provider to not only use data without any consent, but also to sell it without any consent. So I'm going to go back down to consent and ask the question that actually Dr. Martin asked before. And okay, we know what the regulations allow, but what does ethics have to do with this? How do we think about this ethically? And how should we think about the question of, is consent necessary in any of these cases from an ethical perspective? So I think that there are a number of reasons, ethical reasons, that support the idea that we should get consent from people if we intend to store and use their data and samples for secondary research. And what are some of these reasons? It shows respect for them and allows them control over whether or not we do research with their data or samples. It allows them to decide whether the risks or burdens are acceptable to them if they can imagine what they are. It allows them to decide whether, as Dave Wendler pointed out, whether they want to contribute to the goals of research, whether they're okay with that. And it also promotes public trust because people then know we ask before we use your data or your blood for research. However, there are lots of arguments that people have put forth against the need for consent for secondary use. And these include that this kind of research is very low risk or has, and some people say no risk, and it's further mitigated by other things that we can do to reduce the risk, like de-identification perhaps, or data security, or other kinds of methods like that. Many people argue that consent can jeopardize the science, and that is if we ask people to give consent and they say no, then we have to separate out those people and who are they, and maybe they're, distort or skew the pool of people who do say yes. There's enormous cost and complicated logistics for obtaining and tracking consent. And it's probably naive to think that meaningful consent is even possible in a busy clinical environment. And data suggests that the public generally does support research with data and samples because of the potential value to society. So a few years ago, we had a paper that we published based on a conference, that looked at different types of consent for the secondary use of biospecimens or samples, and said that there's a spectrum. There's a spectrum of options with respect to consent that goes from no consent to study-specific consent in every case, and that this spectrum represents less control and less burden at one end, and more control and more burden at the other end. And in the particular paper and conference, we suggested that maybe broad consent is right because it kind of falls in the middle between those two things. It gives people some control and some options without as much burden as specific consent. I think it's also helpful for all of us to remember that there are distinctions that do matter. You know, broad consent basically means you're giving consent, is what you're giving consent for. You're giving consent for a broad range of options, that some of which are unpredictable at this point in time, to be able to use your data, your samples for research that we can't even define, which is different from specific. We're going to use it in this way at this time to do this purpose. And that distinction is different from important process elements of consent that are not what we're asking people to give consent for, but how we're asking them to give us consent. And that can be one-time, recurrent, or dynamic. It could be opt-in or opt-out. It can be verbal or written. And we could imagine both specific or broad consent that was recurrent, or that was opt-out, or that was verbal instead of written. Now, dynamic consent is something that's gotten a fair amount of attention, especially in biobanks and with the use of samples. And basically, that's dynamic consent is a process. It's a process that allows and it's a technology-based platform that allows interaction between the person whose data or samples is going to be used for research and the people who are using it. And it can be used to a broad range of the use of samples or data, or they could opt to be approached on a case-by-case basis. They could set different preferences for different types of research. They could ask to get information along the way, or say, don't bother me unless such and such happens, that kind of thing. So it gives them lots of control over what they get. This is probably not so easy to see, but this is just one example from something called the Dynamic Consent Prototype Interface, which allows people to make some choices at the beginning about what kind of research they want to allow, and then gives them information along the way about how their records have been used, for what purpose, and what their samples have been used for. And they can make changes along the way. There are lots of other proposed methods for consent for secondary use. They include notification, which, as Dave spoke about a little bit before, is just giving people information without necessarily asking for their permission. Cascading consent is an idea that some people have proposed, which is basically you start with blanket consent, and if somebody doesn't like it, then you go the next level down in the sort of spectrum of consent in terms of increased control. Some people have argued that we have the wrong paradigm. We shouldn't even be thinking about donation of data and specimens, but we should be thinking about borrowing them, giving them to the researchers as a loan in trust, and that they should be used carefully as stewards of those valuable resources, and then return something back to the people from whom they came. Some people have argued for something called consent to governance, which is just you give consent to use my data and research specimens, but there is a body of governance that oversees how it's done and pays careful attention to things that we care about. And then there's a lot of people who have written about participatory governance, which is different in the following way, and that is that the sources, the donors, are part of the governance structure in a number of ways, whereas consent to governance, they're not. I mentioned a lot of people have been working on this, and this was a book that came out 2 years ago from the group at Petrie-Flom. Emily was part of that group at that time. I also wanted to mention some of the empirical data that supports what ought to happen with respect to consent. So there have been lots of empirical studies that have asked for people's views about consent for secondary use of their samples or their biospecimens. And when asked, most people are willing to donate their samples and allow them to be stored for research, but the vast majority want to be asked. They want to be asked whether or not their samples can be used for research. Most of them don't care about the specific details, and the majority in the studies that have been done support a notion of broad consent, meaning they're willing to have their research used for a pretty broad range of, their samples used for a pretty broad range of research after initial consent without having to be asked anymore, with some exceptions in terms of both people who agree to it and the things that they want to agree to. I think what's challenging at the moment is what is broad consent. And I mentioned what's in the regulations. There's a lot of discussion of broad consent, but I don't think consensus on actually what it means and what it looks like. And a lot of people are now talking about the old broad consent and the new broad consent, and it's a confusion of terms in some respects. And here's a great example. I think this is a very good study that has interesting data on the use of the consent for secondary use of biospecimens. And you can see a range of types of consent with, at one end, blanket consent, which is just open to anything, and at the bottom, real-time, specific for each use. And I would contend that the three in the middle, even though none of them are called broad in this study, are all versions of broad consent. They're consent with caution, consent with an option to withdraw, consent with combined some limits. They're all some version of broad consent. So there's some confusion about what broad consent really is. There's also some data available on what people think about the secondary use of their data as distinct from their samples. David and Ben's ROMP study was already mentioned several times, but I think what's really interesting is that most people in that study wanted to be asked for permission to use their data in their medical records, even though they were willing to accept non-written consent to do that. There's been some other studies that have looked at how people think about sharing data. So the sharing data through health information exchanges, and in that study anyway, more people were willing to share de-identified data than identified data. And another study that showed that people favored dynamic consent in the setting of sharing data also pointed out that people were more comfortable with anonymized data sharing, and they recognized the benefit of it. I think the last one is really interesting and was just published recently. A fairly large cohort of people who had strong support of broad consent for secondary use of data and strong support for using clinical data for secondary research without consent. And this is in Europe after GDPR was already in place. So I think data is where the action is, actually, at the moment. Many of you have probably heard this. The most valuable resource is no longer oil, but now it's data. But a lot of people have pushed back and say, no, that's not true. There's so many differences about data from oil, and we are amassing data at such a huge rate, we don't even know how to use it. We're siloing it. We're making it inefficient and inoperable, and it's a mess. And this is also true for health data. And health data alone, as this article says, doesn't account for much unless we figure out better ways to extract it. All of this, I think, is relevant to the question of consent, because if people are worried about their privacy and worried about, and we're saying to them, we're using data in ways that's very valuable, we should be pretty sure that that's true. We have to be sure that we are using it in valuable ways, because then people might be more amenable to using their data in certain ways that we're not asking them specifically about. There was a paper that just came out less than a month ago where Effie Parasigius and Lizzie Pike and Devin McDraw, they're asking now for a new Belmont report for health data. And interestingly, in this paper, they recognize that implementing notice and consent is an essential part of this, an essential first step, but it's not sufficient. So where are we with consent for secondary use? I think there are ethical reasons and public support that generally support public opinion, excuse me, that generally support consent or permission to use data and samples for secondary research. However, there are many still argue that it's not worth it, that consent is not worth it because the research is great value, the risks are low, meaningful consent is difficult, and there are significant costs. So I think we're still in the debate mode of whether and how consent is needed for secondary research. I think many people do favor, both professionals and the general public, broad consent for samples and data. And there seems to be a growing discussion of what are sort of generally classified as patient-driven and dynamic models, where the patients are the center of deciding what happens and in patient-driven collaboratives. Last, I just want to say a few words about learning healthcare systems, because what I was just talking about is true for secondary research across the board, but learning health systems actually rely on data and secondary use of data and samples. And there's certainly the need for increased sharing of health data in order for a healthcare system to work. And yet, the people that have looked at this also recognize that there are formidable impediments. And some of them are the ones that David Magnus was talking about, in terms of biases and how the algorithms are created. But many of them are related to that we haven't yet figured out what the right model is for consent, and whether or not, or under what circumstances we don't need consent, and how we're going to make those decisions going forward. So it seems to me that in a learning health system, in a given learning health system, there could be a way to include consent for secondary use right at the front end. When you're getting consent to be in the learning health system, you could have consent for secondary use embedded in that process. The learning health system community could provide input on when consent is needed, for what purposes, and how to implement broad consent if that's the right model for their particular kind of research. And they could also consider, in certain cases, depending on the context, opt-out with notification, participatory governance, dynamic consent, and participant-driven models. I do think we need lots more attention to the question of de-identification. What role is it really playing? Does it really protect anybody? Is it meaningful, as you said so eloquently earlier? What level of public engagement and community engagement should we be building into all of these systems, and how well is the public aware of what secondary use of research data and samples is about? More agreement on when consent might be unnecessary, better data on effective models of obtaining consent, and more looking into this participant-driven model idea. Thank you very much.
Right, whoever branded it's thrilled that I can remember what it's called. But he was a Native American IRB member, and more than that actually, stood up and explained the outrage that that many of the Native American nations and the like had felt about this, because they basically had been kept out of any IRB review, and their specific concerns weren't being addressed and the like, which I thought was sort of an interesting comment. But also one of the things they mentioned, and they just said, is that one of the uses that was already being pushed, but obviously not in our community necessarily, was algorithms to determine familial relationships so that they can find terrorist families and networks easier. That is certainly not medical necessarily, but frequently the consents don't make clear what sort of unrestricted use you're giving. They don't know whether it's for medical or the like. So I just wonder, how do you grasp that? And then secondarily, I mean, I'm not an ethicist, but it always struck me as odd that simply taking my name off a sample or a name off my data lets people do unethical things with it, it sounds like. That they could do things with me that I would find morally repugnant, potentially, and I wouldn't know, but somehow that's okay. And I don't even know how to process that, because no, it doesn't seem to bother people when they do it, and I just don't know how we're supposed to address that. So
great questions. I think I'll start with the latter one. I think a lot of people share your sort of doubt that just taking identifications off something makes it okay to do anything you want with it. And I think that's part of the reason that public preference data, oh, sorry. I didn't, now you can hear me. Part of the reason public preference data suggests that people do want to be asked. They do want to be asked and know. I think you raise another question, though, and that is in that same question. Once you're asked, you still might care what is done with your sample. And that's why I think many people, when they think about this carefully, like some kind of model that includes not only being asked, but some kind of governance that makes sense, and a way that you can get access to how things have been used if you want to know. And so that kind of a model makes sense. It's still, many people push back on that because it does require not only a way to ask people in the front end in settings where it's really hard, but also keep track of what they say. And that's really logistically expensive and complicated, but not impossible. So that's important. I think the All of Us study describes what they have as a participatory governance structure. In other words, they're members of the, All of Us population are part of the governance structure. But it raises a lot of really interesting questions for me, and that is one about, bias and representation. Who are the people who are representing the million people? And are they really representing, how can they possibly represent the million? So it's a very tricky thing to guarantee that participatory governance, I can't say the word, is representative in any way. I think you raised the issue that Native American tribes do feel very strongly about, and that is that they want control over how their data and their samples get used for research. And they want to be able to say, not only as individual members of the tribe, but importantly as tribal leaders and tribal councils. And so I think there's a lot of debate going on about how to do that, but I think there is recognition that their need to be sort of sovereign nations is going to be respected, and they will be exempt from some of the rules about data sharing and things like that. I don't know if you have any.
Maybe one more question, Rosamund?
Okay, so one of the things you ended up with, Christine, it was patient-centered informed consent. But the data that you were presenting showed a huge preference for being asked, and that you see that in studies about patients, do they want to be informed of their terrible prognosis? 95 to 99% across the world want to be informed. Jeffrey Botkin's work about the blood spots, people wanted to be asked. Now, beyond that, I haven't seen any tremendous evidence of wanting to know more. So, of course, as Glenn said, there are a few people, and you recognize there are a few people, but medicine, we're always dealing with what works for the most part. Why so much attention to what those few outliers say when you're asking them, do you want your sample to be included? And they could say no.
So, well, I think there are two interesting ways to think about this. One is that most people, at least in the studies that have been done, most people say yes, they want to be asked and they want to give permission. And the majority of those people don't care about the details. They don't want to know the details. They don't want to be bothered being repeatedly asked. However, there are cohorts of people who want control over their data and their specimens. And I think that group is growing in maybe at least visibility, if not size. And so there are a lot of people talking about these participant-driven models. There was a paper recently about participant-driven collaborative data models, which the idea being that the data is owned by the individuals, not by the healthcare system, and that they should drive how it gets used, where it gets used, who has access to it, et cetera. Now, there's an appeal to that model, right? If we think that data is about me and I should have control over it. And maybe even more so if I have some kind of a disease and I want to see it used in a certain way and, want to have some control over that and recognize that there's so much data that's not under anybody's control. Giving me more control over it makes sense. But the logistics of how to do that are just mind-boggling in my mind. And, the paper that I'm referring to was Barbara Evans and Harlan Krumholtz, and they talked about, we are stuck in, and I thought to myself, I guess I am, stuck in a 20th century model of what consent ought to be and how data ought to be owned. And we need to get out of that. We need to get in a new era. And I mean, certainly the technological capabilities allow things that never happened before. So I think I'm not answering your question very well, but I just think it's really interesting to think that maybe we are at the edge of something very different in terms of how research gets done with data.
Some of the questions where you find a few people who want more information and control, do you think that relates to the way the question is asked or what the particular questions are? Does the interest in more knowledge come from the question, or are these concerns that people would have had sui generis?
It's probably both. I don't know if they match. I'm sure there are definitely people who want control over their data. There are other people who don't want to give anybody else control but don't want control themselves. And so I think it's just all over the place. And I think you're right, in many models of broad consent, or consent like broad consent, it just makes sense to say, we're going to use your data or samples in these ways. This is the kind of governance that we have or whatever. And if you don't like that, then you just don't give your sample. I mean, that's certainly a reasonable way to proceed as well.
So I was going to follow up on that last point, which is I'm always struck by the fact that when it comes to research with samples and data, there's 37 different models. We ask people what they want. But when it comes to a clinical trial, we don't say, okay, would you rather have the nurse come in for 5 minutes and then the surgeon come in and then you get a lunch break and then you get to think about it. You don't get those options. Like, here's the way we do consent. So we're going to do it. If you don't want to do it that way, you don't have to be in our trial.